Facebook. For those of us who are joining, we'll get started in just a few minutes. We're just waiting to get our stream set up. Okay, now it looks like we are streaming live on Facebook, so we'll get going. My name is Sharon Bogan from Communications here at Public Health Seattle and King County. Thank you all for joining us this morning as we give an update on our COVID-19 situation. And without much more to say on that, I'm going to turn it directly over to our health officer, Dr. Jeff Duchin.
Thanks, Sharon, and thanks everyone for joining today. Over the past 6 weeks, after the winter Omicron surge subsided, COVID-19 reports have been gradually rising, and today King County reached CDC's medium COVID-19 community level. This was not unanticipated as the more contagious BA.2 variants spread both locally and nationally. During the winter Omicron peak, our 7-day case incidence per 100,000 was over 2,100. It fell to 53 per 100,000 for 7 days in mid-March, and it's now risen to 214 per 100,000 for 7 days. Today's level is approximately 4 times higher than the recent low in mid-March after the Omicron surge, and about 1/10 of the peak that we saw during the recent surge. During this time, hospitalizations have fallen from a peak of about 19 per 100,000 per 7 days during the Omicron surge in February to about 2 per 100,000 per 7 days recently. All ages are trending up recently, but the highest rates continue to be in young adults, while older adults and children under 5 years have the lowest rates. During this time, hospitalizations and deaths have remained at stable low levels, comparable to the lowest levels we've seen between other pandemic waves. And this is thanks to the protection that vaccinations provide from serious illness. In King County, 85% of those who are eligible have completed the primary series, and 2/3 of those between 50 and 64 years of age have been boosted, and 86% of those 65 and older have received a booster. Now, we know unvaccinated people continue to be at much higher risk of serious illness, hospitalization, and death compared with people who are vaccinated and up to date on their booster dose. This has not changed. The CDC medium risk category is not a magic threshold, meaning the COVID-19 pandemic locally is suddenly or fundamentally different, or that we're approaching a crisis level. But it does tell us that COVID-19 infection risk is increasing for individuals and the community. And as we've discussed previously, we know many cases are not reported and counted. But just because a case isn't counted does not mean it doesn't count. All cases count because long COVID may occur in 10 to 30% of cases, and it can cause long-lasting fatigue, difficulty thinking, and heart and lung problems that can make it difficult or impossible to work and do normal activities. Long COVID is most common after severe infections in hospitalized people, but it can happen even with mild cases. It's important to know that long COVID is less common if you're vaccinated. All cases count because someone with mild or asymptomatic COVID-19 can spread it to someone who's at high risk for a serious infection because of older age, immunocompromise, or other underlying medical conditions. So why is this happening here now? Well, it's happening not only here, but in many places across the country. Personal and community risk increases when we take fewer precautions, when a new virus variant emerges that spreads more readily, like we're seeing with the current BA.2 variant, or a variant emerges that causes more severe illness or dodges protection from vaccines and past infection. And it can occur if protection from vaccination or past infection drops over time. Given the cases are not rising rapidly and that most people at high risk are vaccinated and well protected, and that hospitalizations and deaths remain stable and low, we are issuing no new recommendations or requirements at this time. No new restrictions at this time. But we should see this yellow traffic lights as a slowdown and use this opportunity to lower our risk and the risk for those around us, and to think more about how we'll manage the ongoing challenge of COVID-19 sustainably over the long term. Taking specific actions and precautions as individuals, as business leaders, as a community can decrease the risk for infection and help protect others. It's most important to be sure you're up to date on all recommended COVID-19 vaccine doses. Get a booster dose when you're eligible for the best protection, especially against severe disease. If you know someone who's not up to date, help them get the doses they need. Help people understand that this is the best way to stay out of the hospital, to stay out of the graveyard, and to avoid long COVID. In businesses, workplaces, and other indoor public spaces and in homes, we need to pay attention to improving indoor air by increasing ventilation, HEPA filtration, and other strategies like germicidal UV. Remember that crowded indoor spaces, poor ventilation, and indoor aerobic exercise, singing, and loud talking all pose increased risk. More time in these settings equals more risk. So ask about what's being done to improve indoor air in places where you spend time. If the air seems stuffy, ventilation may not be good. Look for open windows and doors. That's an easy way to accomplish improving ventilation. Outdoor activities and outdoor dining are generally lower risk. Information about improving indoor air quality is available on our website. The EPA has also recently released their Clean Air Buildings Challenge, and that has guidance to help businesses improve indoor air quality. To decrease the risk for yourself and for others, wear a high quality and well-fitting mask like an N95 respirator or a KN95 mask, especially in crowded indoor spaces. And this is very important for people who are immunocompromised, have high-risk medical conditions, and older adults and those who are unvaccinated or not up to date with their vaccinations and booster doses. Consider rapid testing before indoor gatherings, especially if high-risk people are present, and test and isolate if symptoms develop or you've been exposed to someone with COVID-19. With that, I'll pause and welcome questions from you.
Thanks so much, Dr. Duchin. And we put several of the links that Dr. Duchin mentioned in the chat. So you can find the information about EPA as well as our from Public Health Seattle King County about how to improve indoor air quality, as well as the recent blog that we just posted with some of the information that Dr. Duchin has just shared. So with that, we'll take questions. And just as a reminder, if you can raise your hand in the raise your hand function, that will be great. And a reminder to say your name, please, and also your news outlet. And with that, we will get started with Nick Popham. You can go ahead. And looks like we're having a hard time, Nick, unmuting. So we'll come right back to you. Just give us 1 second here. And it looks like our—
Can you hear me?
Yes, now we can. Go ahead.
There we go. Fantastic. All right. Thanks so much, Dr. Duchin, Nick Popham over at Como. I was wondering, are we concerned at all about hospitalizations where we are right now? I mean, I saw according to the dashboard, we've seen an increase in about like 119%, even though that's going from like 5 on average to 10. So I'm wondering, are we concerned at all seeing cases go up? Are hospitalizations expected to follow suit?
Well, Nick, we are at levels now of hospitalizations that are comparable to the lowest levels we've seen in between surges throughout the pandemic. So relatively speaking, very low levels. On Mondays, we always get a batch of new hospitalizations reported, and we post that. It does make the numbers go up, But I think you'll find that those numbers will come down over the next couple of days as the team reviews those records to take out those people who are not hospitalized for COVID-19. So, for example, patients who come in for surgery for a broken bone who have no symptoms but get screened and tested positive get reported. But we don't consider those to be COVID caused hospitalizations. So the numbers are always a little bit higher on Mondays. That said, they've been relatively stable for the past 6 weeks, which is very reassuring. And this is a trend that we're seeing nationally where cases are increasing. Many people are being infected by the highly infectious BA2 variant. And most people, because most of us are vaccinated, are not getting serious infections. And that means most people are not being hospitalized and the hospitalization rates are not rising in most communities. However, that doesn't mean it can't happen. We are definitely concerned about hospitalizations. Personally, I would like to see hospitalizations go down to zero, but I'm not sure that's realistic. But I would like to see them stay as low as possible and would also like to limit the number of cases for the reasons I described, because of the complication of long COVID and the fact that when there's more transmission out there, there's more risk for the people who are especially vulnerable. At the same time, we have to realize that, COVID-19 is not going away. It's going to be a long-term challenge for us. There will always be some degree of transmission out there, at least for the near future. And we need to find ways to coexist that are sustainable, that decrease the risk, that protect the most vulnerable, and that are also realistic for people to carry out.
Thanks, Jeff. We'll go to Erica Barnett. You can go ahead.
Hi, Dr. Duchin. The CDC has a couple of maps that are out right now. One for the general public showing low risk and low transmission rates basically everywhere in the country, including King County. There's a second map that shows higher rates that's supposed to be used by healthcare providers. You commented on Twitter today that the map showing low levels everywhere, including King County, wasn't disinformation. And I just wondered if you can elaborate on this comment that you made, and also, do you recommend that the public use the CDC's map or other sources to get accurate information about their risk?
Yeah, Erica, thanks for asking the question. The reason I do not think the CDC map is disinformation is because the CDC map, although you may not agree with it, and I may not agree with the characterization of green and low risk, it does clearly explain how that determination is made, what metrics go into it, what case rates are taken into consideration to make that low risk determination, and they are clearly telling us that they're prioritizing hospitalizations over cases and assessing the COVID community level. At the same time, they're providing publicly, although it is not as obvious and it's not meant to guide general public mitigation measures, but to guide mitigation measures in high-risk settings like healthcare facilities, the COVID transmission level. And that is the map that shows a lot more red and yellow, because that has different cutoffs. It has a cutoff of 100 per 100,000 cases over 7 days, whereas the COVID community level has a cutoff of 200 per 100,000 cases over 7 days, and then also incorporates other criteria like hospitalization rate and hospital bed capacity. So the reason I do not believe that is disinformation is because disinformation implies a intention to mislead, and I do not believe that is what CDC is doing. I think a lot of people may not agree with their criteria and their assessment of what constitutes high, medium, and low, but I do not believe that is disinformation. That may be unpleasant information for many people, but I believe disinformation really implies an intentional, an intent to mislead, and that is absolutely not what the CDC is trying to do. Obviously, people understand it and they object to it.
Do you recommend the public look at the CDC's map, or do you recommend other sources for information for people who may not go that deep into the data?
Well, if you live in King County, I recommend looking at our website. We show both rates. We show the the COVID community level as characterized by CDC, and we show our actual case rates, and we show a lot more information on our website. Now, if you don't live in King County, or if you do, I mean, the CDC sites are fine to use. They're not inaccurate. Although they have more of a delay in posting the numbers than we do, and so I think ours are more accurate. But in general, they're both reasonable data sources. I just think if you're in King County, we've got more data, and it's displayed in a more useful way. But if you're looking at the CDC site, a lot depends on what you're trying to get out of it. So if you're a person who really just wants to know how much COVID is out there, how much spread is happening, I think the COVID transmission level, which is the map that has the higher level of more red, more yellow, gives you a little more information about how many COVID cases are out there, if that's what you're interested in. If you're more interested in the issue of what's the overall impact as determined by hospitalizations, then the COVID community level, which is the one the CDC is promoting for the general public, is probably more informative. I think there's still a lot of discussion about one or the other, which is more appropriate, which is more informative. But as I said to Nick Popham, COVID-19 is not going away. There will be community spread for the foreseeable future. And as we have more people vaccinated, and unfortunately, as more people who are unvaccinated get infected, and even as those who are vaccinated get infected and get less severe infections, population immunity will build. So cases per se, outside of the issue of long COVID, will be less significant, and they are less significant than they were, in 2020 and 2021, because a much smaller proportion of people who get infected have a severe outcome or an adverse outcome. So, we are moving in the direction where cases are less significant, but they're not insignificant at this point. We haven't reached the point where we shouldn't pay any attention to them at all. So I think both issues of hospitalization and case counts are valid and informative. And depending on what you are personally most interested in, either or both of those may be appropriate to look at.
Thank you. Let's take a question from Dee Dee Sun. Dee Dee, you can go ahead.
Hi, Dr. Duchin. It's Dee Dee with Cairo 7. I had two questions for you. One is, in the beginning of this pandemic, King County broke down where we were seeing more rises in cases. Is that information still being tracked? And is there any information on, for example, like, is there more of a concentration or an uptick in South King County versus North King County? And is that information still being tracked? And then my other question is, it's anecdotally, and maybe it's just, my personal experience, but anecdotally, it feels like we're hearing of more people than, I'm personally hearing of more people getting sick. So are people able to get sick again from BA2 if you've had, let's say, Delta in the past? Do we have that information yet?
Mm-hmm. Thanks for your questions, Dee Dee. So we do track where infections are occurring, and that's posted on our summary dashboard. We've got a number of dashboards on our website. Sharon can put the links in. But if you look at the main page, you get the graphs of cases, hospitalizations, and deaths. But then there's a little tab in the upper right that says geography. And you can click on that, and it shows where cases are occurring throughout the county. And on each of those dashboards, or on many of our dashboards, you can look at the data according to neighborhood and geography and so on. So that is still being tracked. And, as has been true throughout much of our pandemic, neighborhoods in South King County and our BIPOC communities have been hardest hit. Recently, with the BA2 surge, we've seen relatively more cases in Eastern King County and North County. So those data are out there and available to you. And we hope you make use of them. I think they're especially valuable when you look at our vaccination coverage by region. And also you can look at that by age group and by race and ethnicity. And I think one of the most important findings there is that our booster dose coverage is very good in older adults, as I mentioned, but in middle age and younger adults, it falls off, and among our Black and Hispanic community members, falls off markedly. So we hope that data is useful to people in the community so they can understand where vulnerabilities are and identify gaps and see what we can do together to address those and decrease the risk for everyone.
Thanks so much, Devin. Since you mentioned the booster dosage and numbers that we had a question from the community asking, what is the definition of fully vaccinated? I know there was discussion about this recently with the advisory group. Can you just clarify that for the public, and then we'll take some more media questions?
Yeah, the CDC made a good move and updated the definition of fully vaccinated to include all recommended doses, including the primary series and booster. So if you're recommended to get a booster dose, you haven't received it, you're not considered to be fully vaccinated. And again, this is just the recommended doses. So this latest recommendation for your availability to get a second booster, if you're over 50 years of age, or if you're immunocompromised and over 12 years of age, that is not a formal recommendation. That is something that's available to people. And you can discuss with your healthcare provider whether you want to take advantage of that. But that would not go into the definition of fully vaccinated at this time, that second option for another booster. But the first booster recommendation that everyone who received 2 mRNA doses receive a booster, and someone who's received a J&J receive a booster. Those recommendations are part of the definition of up to date now. And if you just Google CDC COVID up to date, you'll get a really nice web page that tells you that which vaccines doses are recommended and which are available, but not recommended, but optional according to what your particular vaccination history is.
Thank you. And we've just put that link in the chat for your reference.
Great.
So let's take a question from Kate Walters.
Hi, Dr. Duchin, Kate from KUOW here. Thanks for doing the briefing today. I wanted to ask you a couple of quick clarifying questions, and then I have a bigger question. I appreciate the mention with the hospitalization data of needing to clean that up. So how would you characterize hospitalizations right now? Would you say they're rising, or would you say that they've remained pretty steady?
No, I think based on the data that we have cleaned up as of Friday, they're very steady since mid-March at relatively low levels, comparable to the lowest levels we've seen at other points in between surges throughout this pandemic. And we're keeping an eye on it. Obviously, that can change, but they've stayed low.
Okay.
We'll see what happens over time. I hope this little surge we're seeing that was not unanticipated as BA2 became more prevalent and is causing more cases will not lead to a significant bump in hospitalizations. But as with everything else about COVID, things are always a little unpredictable. But right now, I would say hospitalizations and deaths are both relatively low in the context of what we've seen before and stable.
Okay, great. And then the CDC map, we are still listed as low. I'm assuming that's just a lag in data, that they haven't bumped us up to medium yet. Is that correct?
Probably. What happens with CDC, they get their data directly from Washington State Department of Health, and they also, so there may sometimes be data transfer delays, and they also frequently report their data on various websites by the date the laboratory report was submitted. So if they get data from the state that's a bit delayed, it can artificially look like there are a bunch of cases happening on the day they receive the data. But we report our data on our website according to when the test was obtained, which is a better indicator of when the actual infection occurred and the timeline of the outbreak. So that's why I recommend using our website whenever possible, our dashboards.
All right, thank you for doing those clarifications. I appreciate it. And then just my question for you is, you said there are no new recommendations, no forthcoming new mandates at this point in time. What is it that you would like the public to take away right now in terms of where we're at and what it means for the way that they're living life?
Well, I think the key message is, COVID is still out there. A lot of COVID is out there, and people know that. Everybody knows someone who's had COVID right now. I can tell, and based on my experience, most people probably know several people who've had COVID. Some people who've had it more than once. And I think a question that was asked earlier that I didn't answer was, can you get it again if you had it recently? And if you've had COVID previously in the outbreak, 2020, 2021, with the Delta variant, that does not provide a lot of protection against Omicron unless you've been vaccinated. Combination of past protection plus vaccination is very good, but even Delta infection alone, if you're not vaccinated, does not provide good protection against Omicron. So vaccination is really important, whether or not you've been infected in the past. A recent infection with Omicron probably provides a relatively good, at least short-term protection against further infection with the same variant. There are always exceptions, but for most people, I think that would be true. So the things that people should understand is, COVID is out there. I don't think anybody really wants to get COVID or wants to risk getting long COVID. And I think it's true that there's a lot we don't know about long COVID, but one thing we do know is that it's probably worth avoiding if you can. And so there are things that we can do both to protect ourselves from getting COVID-19, even if we're vaccinated and not at high risk for serious illness. And that can help us limit the risk to the people in our community who are at risk for these severe outcomes, for people who have cancer, who take immunosuppressive medications, who are elderly and susceptible to serious infections because they may not respond well to vaccine, and to the unvaccinated children who are still waiting for authorization of the pediatric vaccine. So we can do things that will both decrease our personal risk and also the risk to those around us. And I think this is a really good time to remember that those things are not very hard to do. We can improve indoor air quality. We can improve ventilation, use HEPA filters. These things have to be done long-term because COVID, as I said, is not going away. It's going to continue to wax and wane. We'll see intermittent surges, and we would like to minimize the risk that those pose now and in the future. And the way to do that is to take these make these long-term fixes. But in addition, anyone who really wants to avoid getting COVID can achieve a very good level of protection by wearing a high quality respirator like an N95 or a KN95 when you're out and about. And even if you're not overly concerned about getting COVID yourself, you can decrease the risk to those around you by doing that. So again, just understanding that we're still in a situation where there's a great deal of uncertainty about where we're headed, but we are in a much better place than we have been in the past couple of years during the early days of this outbreak with respect to the severe health impacts, hospitalizations, and deaths. However, we're still learning a lot about long COVID. It's probably something we all want to avoid, and we can take some steps to minimize that risk right now. In addition, we are getting more treatments into the community. People need to be aware of this and understand how they can get treatment. The Test and Treat initiative, if you go to the federal website, you'll find that there are literally hundreds of places in King County where Paxlovid is available. And having a plan, if you're a high-risk person, with your healthcare provider about how you would get that prescription in advance, having that plan in advance will be very helpful should you become ill. And then, of course, for patients who are severely or moderately immunocompromised, Evusheld antibody treatment can be given to prevent infection. And we've sent information out to our King County healthcare providers about both of these options last week, about Paxlovid and how to find it, and about Evusheld. And we want our community to know that if you are at high risk because of severe or moderate immunocompromise, make a plan with your healthcare provider about getting Evusheld, or at least assessing whether you're eligible. And again, if you're at high risk for complications because of an underlying medical condition, having a plan about how you'll get your prescription for Paxlovid if you become ill through your healthcare provider. These types of things are just really important to lower the overall impact of this disease, both now and going forward.
Thanks so much, Dr. Duchin. Let's take a question now from, Sally James from Seattle Emerald. You can go ahead.
Hello, thank you so much. So I want to ask if you could walk us through, from the point of view of an epidemiologist, whether we have or haven't already witnessed any impact from the spring break of the Seattle public school system.
Well, thanks, Sally. Spring break happens at different times for different schools and for our colleges and universities, but lots of things happen on spring break, including travel, which we know is a high-risk activity, family gatherings, parties, and so on. All of these things can impact COVID transmission. We think that spring break and travel nationally could have an impact on COVID, but there's really no way to know that with certainty. There's not a way that we can sort out, all the different things people do on spring break and what the impact of traveling versus socializing, might be. There are communities such as New Orleans where spring break is traditionally a really big party time, large crowds come in, lots of socializing, lots of bars and close contact where they did not see big surges after spring break. So, a lot depends on the underlying immune status of the population. Were they recently infected? We had a pretty big COVID wave here, in January and February. A lot of people have protection from being reinfected with that virus, which is still the predominant variant. So that has a lot of impact on, whether or not spread will occur among the recently infected. And it's just very difficult to tease that out, from, a school break schedule. So I can't really tell you with any certainty whether spring break has made a difference. I can say that, our rates have been rising sort of steadily. We didn't see a bump after spring break in transmission in any age group. The reports from schools, have been relatively low compared with what they'd been over the winter time. Reports of outbreaks in the community from community congregate settings have been relatively stable and low compared to what they'd been earlier. So, it's just it's not possible for me to characterize whether spring break per se, has had much of an impact given all the other variables that drive transmission.
Okay, thank you.
You're welcome.
Thank you. We'll get to a couple more questions here, but we are getting lots of really excellent questions from folks in the community. So I wanted to just ask you one now, Jeff, and then we'll try and get to a couple more. There was a question saying my office is in the center of an office building floor. I have no windows to open for ventilation. I think folks are really starting to recognize how important this is. Do you have any guidance for those in the public of things they can do if they're in that situation? Any thoughts on that?
Yeah, well, the first thing would be to talk to your building managers if you can and ask them what they're doing to improve indoor air quality. There are some very clear-cut recommendations now, from the EPA, available in multiple places, EPA website, CDC. We've got some on our own King County webpage about how, buildings can take steps to decrease the risk of COVID spread through increasing indoor air intake, through recirculation, through filtration filters, if they're MERV 13 or higher, through HEPA filtration. If it's a type of building where you can open windows and doors, that's great. But yeah, I think the first step is to talk to your building managers and see what they've done. And then you can actually measure indirect measurement of ventilation in the building using portable carbon dioxide monitors, something like the ARANET 4, ARANET 4. It is, tiny. You can just carry it with you, or maybe someone who has one. See what the carbon dioxide levels are. That's an indirect measure of the adequacy of ventilation and indoor air quality. If there's a lot of filtration going on, that level won't correlate with the COVID risk, though, because even though the air may not be ventilated well, if it's getting filtered well, that takes the virus out. But in the absence of filtration, if you have a high level of carbon dioxide in your environment, that implies that the risk of COVID-19 lingering in that air, that stagnant air, is also high and would be a risk. So I think those are the key things, to start with. And then if your employer is open to it and they're not aware, educating them about the things that can be done to improve the indoor air quality in the building. And then if that isn't satisfactory, taking steps like wearing high quality masks like N95 masks and decreasing the density of people in the space could be helpful. Well, I would say would be helpful.
Thank you for that. Elise Takahama, you can go ahead with your question.
Hi, Dr. Duchin. Thanks so much for doing this today. Thank you for talking about the new hospitalizations and staffed inpatient beds, but I was also wondering about general hospital capacity in King County right now, and is that still being pretty affected by delayed care and influenza levels as well?
Mm-hmm. Yeah, thank you, Elise. In general, the hospital burden from COVID is very low right now. Below 5% of hospital beds are occupied by COVID-19 patients. And the number has been hovering, between 1 point something and 3 point something here in King County. But the hospitals still remain very full for a number of reasons. Not that we're seeing a lot of flu activity currently, although I worry a lot about the day when we will see superimposed influenza and COVID-19. I think that's going to be a tremendous challenge to our healthcare system. And another reason we really need to think seriously about long-term strategies, not just the next few days, to control COVID-19 and bolster our healthcare system capacity. But there's a large backlog of care, people who put off getting treated and people who couldn't get treated because our hospitals were too busy with COVID-19, deferred surgeries and so on. There's also, I think, ongoing issues with ability to discharge patients from hospitals. So there are a significant number of people sitting in hospitals that don't need hospital care any longer, but don't have a place they can go in the community. And I would refer you to the Washington State Hospital Association for the most up-to-date take on the status of what's being done to address those really important questions. Because for all of us, if we have a COVID surge or a flu surge or an earthquake or any other reason why we need to be a patient in a hospital, we need hospital care. We want that hospital to be there for us. We want them to have the staff and the space to take care of us. And there were a lot of gaps and shortcomings uncovered by the COVID-19 pandemic. And they haven't all been resolved, and the threat of the COVID-19 pandemic is not gone. And the very realistic expectation that we'll see COVID and influenza and other things like climate-related disasters like what we saw in the summertime with the extreme heat event. We'll have wildfire smoke again. We've had flooding. All of these things end up causing significant human health effects and requiring people to seek hospital care. So the stress on our healthcare system over the long term is something that deserves, very careful attention now, and all of our best efforts to try and address before we reach another crisis. But I think that, again, the Washington State Hospital Association will have the most up-to-date information on the progress that they're making with the difficult to discharge patient issues and their staffing situations.
Great, thanks so much, Jeff. And let me grab one more question for you from the community, and we'll have other links and responses to folks in the chat as well. And then we'll make sure to get Nicole Jennings as the last question. But here's a question that I think a lot of folks are asking about, which is for parents, particularly who have kids under 5, feeling like the vaccine situation is incredibly frustrating. And I know we've heard that from our community. And so the question is there anything that can be done or that we're doing either at the local level or at the state level to, in the community members' words, hurry up with getting our youngest kids better protected, that the parents of those living with little ones are living like it's 2020 with daycare closures, et cetera, is what the comment was. So I just wanted to know if you had any thoughts on that.
Yeah, well, I am extremely frustrated with the timeline of the vaccine for these young children between 6 months and 5 years of age as well. We are all, I think, just really exasperated with how long this is taking. I can tell you that in King County currently, children between 0 and 4 years of age, up to 5, have the lowest rates of COVID-19 reported, which is good. And as you know, they do not have the same high rates of severe disease as adults do. But nonetheless, they do get infected and it's disruptive, and some of them become very ill. So we do want them to have the opportunity to be vaccinated as soon as possible. I don't think, other than the advocacy that we've continued to put on the federal government through our public health system, I don't know what we can do to speed the process of the vaccine authorization by FDA. I mean, I think there's been a large national outcry. I think that the FDA's heard it. I hope they respond. The most recent media reports suggested that they might delay licensing the Moderna product until the Pfizer product was ready to be evaluated. I hope that they reconsider that decision. In the meantime, as always, anything that decreases the risk of COVID-19 in the community decreases the risk for high-risk people in the community. And that includes people who are unvaccinated and unvaccinated children, but also immunocompromised people who have underlying high-risk medical conditions. So it is a reason for all of us to consider doing more, if we can at this point, to prevent the spread of COVID-19 through taking indoor air quality very seriously in our workplaces, our businesses, other public settings, to doing what we can to wear masks in indoor settings where other vulnerable people may be, and to use testing as much as we can. At-home tests, although they're not reported, and that's a little bit of a frustration for public health folks, they're very valuable to the community in helping you guide your behaviors. So you can test before being around susceptible people, before gathering, certainly test if you have symptoms, and isolate if symptoms develop. And if you want to be especially cautious, and I think it's a good idea, test yourself when leaving isolation on day 5 or anytime before day 10 to ensure that you're negative, and making sure you take the precaution of wearing high quality mask through day 10 if you leave isolation before that point. So I think those are the things that we can do. And I certainly hope that we see some more accelerated progress on the evaluation of the pediatric vaccine very soon.
Excellent, thank you. And for our last question, we can go ahead as we wrap up here. Nicole Jennings.
Good afternoon, Dr. Duchin. This question is for Cairo News Radio. I understand why we're not having any new restrictions at the moment since hospitalizations and deaths are still low, but what would it take to bring back any mandates that we've previously had, and what might those restrictions be if they did come back?
Yeah, thanks, Nicole. I think the key thing obviously would be something that threatened our healthcare system again, either a rise in severe illnesses or the number of hospitalizations that again made it very difficult or makes it very difficult for our healthcare system to function normally and leads to their inability to provide the usual type of care that we all want and expect when we go to the hospital. The types of things that that would be on the plate, I think, are limited now because we have so many interventions that don't require mandates and restrictions, like the availability of vaccine, and we have a very highly vaccinated population, right? So it wouldn't make sense to have a vaccine requirement at this point when we've got the vast majority of our people vaccinated. Now, some businesses may elect to do that to protect their workforce, but community-wide, I don't think that would make a lot of sense given the fact that we've got so many people already vaccinated. But indoor masking is one that I think is more reasonable to consider going forward if things got out of control in the healthcare system, or we were worried that they were going in that direction, if we had indication to believe that the healthcare system or something fundamental is changing about the severity of illness with the emergence of a new variant that evaded immunity, and we see lots of people getting sick very quickly, either here or elsewhere. Ensuring high compliance with indoor masking could be an option. And then I'm hoping that at some point we can make progress with some sort of standards around expectations for improving indoor air. That would also help us decrease the risk of spread, in locations where we know a lot of spread occurs.
Thank you so much for that. And we'll put a few more resources into the chat here. One of the ones, given that Dr. Duchin was mentioning support for ventilation and improving air quality, our public health team does provide technical assistance to smaller businesses and childcares who may be looking at their own situation and how to improve that. So feel free to check out our website if you're interested in getting that kind of support. And then also we have a resource that we posted just this morning with a video with some audio as well that provides some of our key prevention steps that Dr. Duchin provided, so that you can share with communities, as well as some downloadable slides. So feel free to use those resources as you all see fit. And with that, I'll turn it back over. Any last words from you, Dr. Duchin, to close?
Thanks, Kate. As always, thank you to those who joined us today and who view this briefing on video. We've run over, so I want to be brief, but I do want to remind everyone the threat from COVID-19 has decreased substantially, but it's not disappeared. No one can predict when or how much more cases will rise or when they will fall. But I would expect ongoing ups and downs for months to years based on what variants emerge, population immunity, and other factors. And so for this reason, let's think about long-term sustainable COVID-19 prevention and treatment strategies as our top priority. Thank you again, and I look forward to talking to you again soon.
Great. Thank you all. Have a good afternoon.